Good day to everyone joining us and welcome to today's X-Talks webinar. Today's talk is entitled Clinical Endpoints and Treatment Effect in Immuno-Oncology. My name is Ryan Muse and I'll be your X-Talks host for today. Today's webinar will run for approximately 60 minutes and this presentation includes a Q&A session with our speakers. Now the webinar is designed to be interactive and webinars work best when you're involved, so please feel free to submit questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel on the right-hand side of your screen. If you require any assistance, please contact me at any time by sending a message using this chat panel. At this time, know that all participants are in listen-only mode, and please note that the event will be recorded and made available for streaming on xtalks.com. At this point, I'd like to thank the International Drug Development Institute who developed the content for this presentation. The International Drug Development Institute, IDDI, is an expert center in biostatistical and integrated e-clinical services for pharmaceutical and biotechnology companies in several disease areas, including oncology and ophthalmology. IDDI optimizes in clinical development of drugs, biologics, and devices thanks to proven statistical expertise and operational excellence. Founded in 1991, IDDI has offices in Belgium, Boston, Raleigh, and San Francisco. And now I'd like to introduce our speakers for today's event. Tomasz Berzykowski has been working as a professor of biostatistics at Hasselt University since 2002. He held a visiting professorship position at the Department of Medical Epidemiology and Biostatistics at the Karolinska Institute in Sweden, and he has been involved in interdisciplinary research in numerous biomedical studies and clinical trials. He serves as a member of the Executive Committee of the International Society for Clinical Biostatistics. Everardo Saad has over 15 years of experience in medical oncology and clinical trial designs. He graduated in medicine and trained in internal medicine at Sao Paulo and did his fellowship in medical oncology at the University of Texas MD Anderson Cancer Center in Houston. After practicing for several years, he shifted his professional career towards education and research in medical oncology and has a special interest in clinical trial methodology, the assessment of endpoints, and the development of novel therapies for cancer patients. And so now, without further ado, I'd like to hand the presentation over to our first speaker, Everardo. You may begin when ready.
Thanks a lot, Ryan. Hello to everyone. Thank you for attending this webinar. So our plan for today is as follows. I will divide our presentation in two parts. I'll start by reviewing some general issues related to immuno-oncology, or IO, especially the dynamics of response, as well as just a few things about response assessment and just a brief overview of the criteria. And then I'll switch gears to talk about time to event endpoints, concentrating on overall survival. And this will set the stage for the part where Tomasz will describe some problems related to the assessment of time to event endpoints, especially OS. And then he will provide a very broad overview of the proposed methods and solutions to these problems. So the first thing I'd like to say is about immuno-oncology in general, and the question is it special, and how special? So we all know that for the past 10 years or so, there's a lot going on in oncology, and most of it is due to immunotherapy in general, because this has really revolutionized some fields, especially in metastatic disease, and especially some diseases which were much difficult to treat, for example, advanced melanoma. And so many people have identified several specific issues that make immuno-oncology different, and a lot of it has to do with the dynamics of tumor responses. And so this has implications in drug development, in trial design, in many of the issues around clinical research. So this is one of the many papers. It was put together by the group at Gustave Roussy, and it highlights some of the specificities of immuno-oncology for phase 1 trials mostly, but obviously this goes beyond phase 1, and there are many specific issues that need special attention in the case of immuno-oncology. So here, most of what we are going to say and the examples we're going to use relate to anti-PD-1 and PD-L1 inhibitors. This is not so new. It's only a partial list now of approved drugs, and some of them obviously are much older in the case of cytokines. But this is a list of approved immunotherapy products about 2 years ago, but just be aware that we're focusing mostly on anti-PD-1 and PD-L1 inhibitors, and obviously anti-CTLA4 inhibitors, the checkpoint inhibitors. Now, again, this is not so new, but some time ago, these authors put together an overview of ongoing clinical trials, and at that time already there were more than 1,000 only with PD-1 and PD-L1 inhibitors. And many were in combinations with other checkpoint inhibitors or chemotherapy or other treatment modalities. So there's a huge number of ongoing clinical trials. And only last week, I did a very quick search in clinicaltrials.gov, and just making a very simple search for these terms, PD-1 and cancer, I found nearly 2,000 ongoing or still to open studies, so not counting completed studies. But this is just to show that there is a huge number of ongoing studies, many of them having a backbone of PD-1 or PD-L1 inhibitors. Now, the most salient feature about drug development in immuno-oncology, or at least one of the two most salient ones, one is this one, the other is the pattern of behavior of survival curves, and we'll talk about that in a few minutes. So this is related to the dynamics of responses, and immuno-oncology has presented us with different and novel issues related to atypical response patterns. And the reason for this is not completely clear, but the most obvious candidate is the mechanism of action of immunotherapy in general, which typically relies on the immune system for its effect. So it's well known that a certain effect, anti-tumor effect, depends on infiltration of tumor by killer lymphocytes and other types of effector immune cells. So this is just immunohistochemistry showing patients who in a clinical trial where they could be untreated or treated with a specific immunotherapy agent. This is prostate cancer, and so when there is lymphocyte infiltration, there is a chance for a response, and so this is probably underlying some of the issues that we'll discuss from now on. So I will address pseudoprogression and the issue of response duration. I will leave the issue of a possible cure for metastatic disease for Tomasz, because some of the statistical issues he'll describe have to do with a cure fraction, and so this is what we're going to discuss today. We're not going to discuss the issue of hyperprogression and some others, for example, the potential abscopal effect from radiotherapy among patients treated with checkpoint inhibitors. Now, some people have come up with the concept of immunoediting, according to which there is an ongoing let's say tug of war between the cancer and the immune system, and there would be different phases in this war. One of them is elimination, where the action of the immune system would predominate. Then there would be a phase of equilibrium, and eventually an escape phase where the tumor would win the battle against the immune system. So some people try to use this theoretical framework to explain some of the patterns of responses. Now, because investigators involved in clinical trials of the early checkpoint inhibitors soon realized that there was something particular about response to immunotherapy, and also a little bit because of historical cases of spontaneous remission or other abnormal behaviors with early immunotherapy interventions. These investigators soon realized that other response criteria might be needed in addition to RECIST or other usual methods of assessing response in oncology. And basically this was because some patients who initially had something that appeared to be progression were still destined to have a response if treatment could be continued, and investigators had the clinical intuition to continue treatment in some patients, and in fact confirm that some of them are destined to respond. As a result of these early observations, over the past 10 years or so, 4 different response criteria have been proposed. And I'm just showing this very nice summary presented 2 years ago at ASCO, just to show the selected features of these 4 sets of criteria. So it's not my goal to go into the details here, but just call your attention to the fact that not everything called iRECIST is in fact iRECIST. In fact, if you compare against RECIST 1.1, there are 4 different sets of immune-related or immune-based criteria, and just one of them has been developed by the RECIST group. It's this one called iRECIST, properly speaking, but there are others, and they have slight differences, such as using bidimensional versus unidimensional measurements, how many lesions are assessed, and what to do with new lesions. So this will vary slightly from set of criteria to set of criteria. And eventually, I think at least that the iRECIST will prevail, but it hasn't, at least to my knowledge, been validated yet. So it has been proposed, it's been used in several clinical trials, very often as secondary response assessment criteria, sometimes as primary, but usually even the RECIST group recommends that we continue to use RECIST 1.1 side by side until iRECIST is validated. Now, the basic issue, as I said, is pseudoprogression, which can be easily seen in this spider plot. So if this was the chemotherapy era, we wouldn't see patients having disease growth continuing on treatment. So this would, the trajectory for these patients would basically stop here because physicians would discontinue treatment. And I'll come back to that in the next slide. But with immunotherapy, in selected patients, if treatment is continued, some of them will respond. And so this is a small set of patients, and we can see that some of them will have, despite an initial tumor growth, very dramatic responses to the point of being called complete responders. So this is what pseudoprogression means. And clinically, this can be observed, for example, in this patient with melanoma. This is before treatment. Then after treatment, there is some tumor growth, then regression, and more than a year later, there is a near complete remission of this of the skin lesions here. Another observation is the fact that people who have pseudoprogression have a prognosis, at least in terms of overall survival, that is much better than those with true progression. It's apparently not as good as patients who have an initial response. So this raises the issue of how important this is, because if we recognize these patients and continue to treat them, they're destined to have possibly a better prognosis. Whether this is from treatment or not, I'll come back to that in the next slide. So the real question, practically speaking, is how frequent is this phenomenon of pseudoprogression? And there are many attempts to summarize that in the literature. This is just, let's say, an average of what we found in just searching the literature. So in melanoma, this is certainly more frequent than in other tumor types. I would say between 7 and 10%. And in other tumor types, such as non-small cell lung cancer, renal cell carcinoma, bladder cancer, and others, it's more like 1 to 2%. Now, the percentages depend on how you define the denominator of this, and I'll come back to that again in the next slide. One caveat in these analyses is that not all trials have allowed for treatment past progression. So this is, in fact, not yet so well known as we might like to think. And so the issue of past progression treatment or treatment past progression has been assessed in several retrospective studies. Interestingly, 2 of them have been published by the FDA group. So one is in lung cancer and the other is in melanoma. So in lung cancer, what they found is that out of 535 patients treated with PD-1 inhibitors, 121 had treatment past progression. Again, this was not something that was done by design in the studies. This was decided by investigators, so there may be bias in this kind of assessment. But they found that 10 patients had a response despite having an initial progressive disease as determined by RECIST 1.1. So depending on what denominator you use for these fractions, you would conclude that 8.3% of patients had a response past an initial progression, that is 10 of 121, or you would think that it's closer to 2% because it's 10 out of all the patients analyzed. So this is one of the issues that I mentioned in the previous slide. It's depending on how we look at this, these percentages will vary. Now, in one of the studies that proposed the criteria that I showed 2 slides before, the setting was lung cancer and bladder cancer. And then in that issue of Journal of Clinical Oncology, there was this editorial in which the author said that he was questioning the real benefit of using new response criteria, because this would raise the overall response rate by only 1 to 2%. So what we need to ask is, what is the benefit of not using RECIST 1.1 and use one of the new immune-related criteria, because we will just make recognize the patients with pseudoprogression, and they will move to better categories such as stable disease, partial response, or even complete response. But apparently this is a relatively rare phenomenon, at least outside of melanoma. Now, interestingly, even in melanoma, so this is the second paper by the FDA group. Now they looked only at studies in which a PD-1 or PD-L1 inhibitor was used in advanced melanoma. And in one of the studies, the continuation of treatment was also allowed in the control arm, in this case, the carbazine, which is not a very effective drug against metastatic melanoma. And it's quite interesting and thought-provoking to think that the overall survival of patients who continue treatment beyond progression is as good with in the nivolumab group as it is in the carbazine group. So obviously, again, this is not a randomized comparison, but it just tells us that these patients may indeed have something prognostic, and it's not necessarily the treatment that does that is responsible for the outcomes. Now, here we don't know how many patients crossed over, which may be an additional complicating factor, but there are many things to take into account when considering whether, in fact, post-progression treatment is something that should be incorporated in a widespread manner, or it's something still under investigation. So this is very, very thought-provoking. I'm not showing here, but among the patients who did not continue treatment beyond progression, again, there wasn't a very big difference in prognosis between the 2 groups. So that's another, let's say, a parallel issue. So when patients have treatment past progression and one looks back, it's important to consider that the initial progression may have been in target lesions, non-target lesions, and new lesions, and apparently target lesions predominate. This comes from the FDA paper that I mentioned in lung cancer. Now, another issue with responses in immunotherapy is the fact that they're not only more frequent as these waterfall plots show, and also of a better quality, let's say, because of the shape of these plots, but also in terms of their duration. So this is comparing pembrolizumab with chemotherapy, and then you look at patients who had a response and look at the duration of their responses. It's obviously they are obviously more durable with immunotherapy as a general rule. This is very recent data from the latest ASCO meeting in colorectal cancer. And this seems to be a somewhat recurrent finding. So the question is, how can we use response duration as an endpoint? And this is a problematic endpoint because it's measured only in responders. So we're not comparing patients on the basis of randomization. And so this is subject to selection bias. And interestingly enough, the bias may go in the opposite direction as we might think. We tend to think that patients in the group with the largest, with the highest response rates will be the best patients, and therefore might have a better prognosis. But these authors have argued that the bias may in fact go in the opposite direction. Just because you have more patients in the arm with the highest response rate, in this set of patients, you may have not only the best patients of that group, but also patients who didn't have such good prognosis to begin with. Whereas in the control arm, by selecting for analysis only the responding patients, you're only taking the patients with the actually best prognostic features. So the bias may in fact go against the arm with the highest response rate. And they try to show this by this analysis in which they compare the control arm with two possible analyses of the experimental arm. One, let's say, naive analysis, which is the pink curve here without taking into account the methods they propose, and the blue curve, which takes account of that method and even improves the duration of response in the experimental arm. So the bias here was going against what is more intuitive to think. So these authors, just to finish this issue, they proposed two methods to try to correct this bias, and I recommend for those who are interested to check the paper because it's very, very interesting. Now, another similar way of looking at response duration, but not as a time to event endpoint, but rather as a categorical endpoint, is to think about the frequency of durable responses. And this has even been used for approval of this immunotherapy agent. And so here we're not looking at response duration as its time to event, but rather how the percentage of patients having response duration for at least 6 months. So this can be analyzed as a categorical endpoint, and in this case, it was even the primary endpoint that led to approval. Now let's quickly shift gears to survival, and we and others have defended in the chemotherapy and targeted therapy era that survival should be replaced by PFS, but obviously with immunotherapy this is not appropriate. It's often the case that many of the available immunotherapy agents have led to gains in survival, and so survival or OS continues to be a relevant endpoint in this field. One of the things that have become really apparent is the fact that there is often a disconnect between gains in OS and gains in PFS, and this is unusual outside of immunotherapy. So this is just an informal pooling of some trials in different disease settings and treatment lines, all of them with gain in OS. Some had gains in PFS and some did not. Now, the question is why? And one of the things that always appear when looking at survival curves for these studies is how they can vary. I would say among three possible patterns, although there are others that I'm not showing here, such as early progression, etc. But sometimes they would look more like proportional hazards, if one can say that, for PFS, sometimes more a pattern of late separation of survival curves, although this is often the case with PFS, even in other settings. So here it's hard to really be sure. And the other one is crossing of the curves. So this is all in lung cancer. So it's basically the same indication with some variation. Sorry, two in lung cancer, one is in melanoma. But if we take the OS curves for these same trials, then we can see what I was referring to, a situation where hazards seem to be more or less proportional, a situation where there is an early overlap and late separation of the survival curves, even to the point of raising the question of cure in a fraction of patients. And then there is the situation of crossing of survival curves. So all this leads to several problems, and for those who are interested, we have summarized some of these issues in a recent paper. It's available online free of charge. So for those of you who are interested, when you receive the recording, you can check this reference here. And so this leads to several consequences, and Tomasz will address many of them. I won't go into the details here. So I will now hand it over to Tomasz.
Okay, thanks, Everardo. Yes, so Everardo already indicated the starting point of my part, which is related to the fact that when we look at these survival curves, we see entire menagerie of possible situations. We have obviously proportional hazards, but we can have situation with a delayed clinical effect, as Everardo mentioned. We can have long-term survival, so almost like a cured fraction, where it seems that there's a proportion of the patients who actually are no longer vulnerable to the event, and then we can have a combination of the two. Now, classically, proportional hazards and analysis based on proportional hazards was standard in oncology, but indeed in immuno-oncology, this is no longer the situation. So we need to think about other approaches to analyzing the data and summarizing treatment effect. So we have to deal with the situations like long-term survival or delayed clinical effect or crossing survival curves, which are clearly leading to more proportional hazards. So I'll be talking about several proposals briefly, which have been put forward for this for dealing with these different phenomena. We'll talk about weighted Logrank test, the use of restricted mean survival time, cure fraction models, and non-parametric approach, which is based on pairwise comparisons. So this is one of the curves. Several have been shown by Everardo. This is a curve from the paper looking at comparison of pembrolizumab versus chemotherapy. And as you can see, these are survival curves for progression-free survival in a particular subpopulation in this trial. And you see crossing survival curves. And traditionally, you see estimate of the hazard ratio and the confidence interval thereof. But clearly, we cannot think that the proportional hazard assumption is fulfilled here. So essentially, this estimate of the hazard ratio is not meaningful because we cannot take the proportional hazard assumption as granted. Now, based on this confidence interval, we can calculate that approximately the Logrank test would have a p-value of about 0.3 two-sided. So if we applied Logrank test to these two survival curves, we would get non-significant result. But well, one might say, hey, this is not really true because we see separation between these curves, although we have early effect, let's say, in favor of chemotherapy, and then late effect in terms of pembrolizumab. So the question is, okay, how should we go about this? I mean, clearly, Logrank test will not capture these differential long and short term effects. And this is where weighted Logrank test comes in. The idea is that in Logrank tests, we essentially compare observed events, say deaths or progressions and deaths, and we compare them with the expected deaths. And the idea is that in constructing the test statistic for a weighted Logrank test, we can use weights, which may make the test more sensitive to differences at different parts of the time coordinates. So we can use different weights. Obviously, we get Logrank tests when we use the same weight equal to 1 to at all time points. K indicates here like times of events in our data. We could use weights related to the risk set or the survival function, and this would essentially mean that we give more weight to early differences. So we could have tests which actually assigns more weights to differences early on the time scale. And Harrington and Fleming propose a very broad family of tests where you can use as the weight the product of the survival function of the combined groups and the complement of the survival function with coefficients P and Q. And by using P and Q, we could actually sensitize the test to different, let's say to late or early differences. So if we take P and Q equal to 0, we essentially get back to the Logrank test. When we use P equal to 1 and Q equal to 0, we essentially get the Peter-Prentice test, so a test which is sensitive to early differences. But by using, for instance, P equal to 0 and Q equal to 1, we could look at the late differences. So it would mean that we could actually give more weight to these differences and actually have a test which captures these differences. And in this case, it would be probably favorable to the non-chemotherapy treatment to Pembrolizumab. Okay. Yes, if we actually apply the test, and this is where Friedlin and Korn in this paper, what they did is they actually applied this test to these curves, and they found that obviously the late difference test was in favor of Pembrolizumab if we apply it one-sided. Well, it seems this an interesting approach, which allows us to conclude that eventually, yes, the novel therapy seems to work. There are several issues with using the late difference weighted Logrank test. Well, first of all, if the treatment effect is not delayed, then using this late difference test will result in loss of a power as compared to the Logrank test. And we don't know this a priori before doing a trial. So, if we choose to use the late difference test, we can actually incur loss of power. Now, result of the test may depend on follow-up and censoring, because again, in order to see late differences, you have to have enough follow-up in your trial. It's important also to realize that the test may not properly account for existence of early harm. And that's why one should really interpret the results of the test in terms of difference rather than superiority, because in fact, we cannot claim that the treatment group, which is indicated by the weighted late difference weighted Logrank test, that this treatment is really superior, because there may be early harm actually. And in this paper, there's a nice example presenting a paradoxical, perhaps, a situation where we have for the control arm the blue survival curve, and for the experimental one we see a very early drop, sharp drop, which is due to a high hazard of events, which later on stabilizes and actually becomes a low hazard. And in fact, if we apply late difference Logrank test to this situation, we will discover that the experimental treatment is actually better than control. And the reason is that the late difference test actually weights more heavily this part of survival curves, which are actually related with the lower hazard rate for the experimental treatment than with the control. So one has to be careful when using the late difference weighted Logrank test. Now, one could say, okay, so perhaps we could get rid of the problem of deciding which test to use and then just make a combo. Use several of the tests and just allow let's say, this combo test to decide, where the difference lies. So for instance, instead of selecting one test, we could combine several. Like for instance, we could take the maximum of the absolute value. This would be a two-sided test for the Logrank test, for the early difference test, and for late difference test. Now, in this approach, you would get improved power as compared to the Logrank test in a situation when the assumption of proportional hazard is not fulfilled. But again, you would get a reduction in power if the proportional hazard assumption does hold. So this choice is, in a sense, robust regarding the differences of survival curves at which we will focus, but it may actually incur a loss of power if, in fact, the proportional hazard assumption holds. Now, it is also interesting to know that if the survival curves are crossing, then one-sided version of this test may reject the null hypothesis in favor of treatment and in favor of control for the same data. In fact, for this example, which I have been showing, if we apply this maximum test in a one-sided version, then we will get a very significant p-value both for pembrolizumab and chemotherapy, because we have early differences for chemotherapy in favor of chemotherapy, but late differences for pembrolizumab. And this maximum test based on one-sided statistics will actually pick that. So yes, using a weighted Logrank test can actually, let's say, highlight the differences or the part of the survival curves which you may be interested in, but one needs to be careful about using the test, interpreting its results, and clearly there may be challenges when we need to decide about the form of the test we want to use when planning a clinical trial. Okay, now what if we want to estimate the treatment effect? I mean, Logrank test, weighted or not, is a testing procedure, but how about estimating the treatment effect? Now, as I said, in non-PH situation, we shouldn't use hazard ratio. Well, idea would be to look directly on the time scale and perhaps to work with the mean survival time. Now, it is possible to estimate mean survival time non-parametrically by taking the area under the survival curve, but this works only if the curve reaches zero. So if it drops to zero, and this is not always or actually rarely the case in practice. So instead of looking at the unconditional mean survival time, the restricted mean survival time has been proposed. Essentially, the idea is to calculate the area under survival curve until a particular milestone, until a particular time, t. And essentially, this would be like an estimate of the mean survival time until time t. Now, this has become popular recently, and you can actually apply this approach to quantify treatment effects and conduct tests. So this is an example of the trial comparing nivolumab versus docetaxel in non-small cell lung cancer. These are overall survival curves. They do cross, so proportional hazard assumption is not fulfilled. If we look at the restricted mean survival time until 24 months, we see that for docetaxel, the value is equal to 11.3 months. For nivolumab, it's 13 months. So the difference in these restricted mean survival times is equal to 1.7 months. And actually, it can be shown that this difference is statistically significant. So we have an estimate of the treatment effect in terms of the difference in restricted mean survival time, and we can actually test this difference. Now, there has been also a proposal for the RMST ratio as an estimate of the treatment effect, which can also be used. One of the issues here is that, well, it's perhaps not so trivial to interpret the value of RMST. What does it mean, the mean survival time until time t? And another problem is, of course, which time t, which milestone you should select. And indeed, statistical significance of the results and estimated treatment effect will depend on the chosen value of t. This significance and the estimated treatment effect may be exaggerated if T is chosen to maximize the significance, right? So you should properly account for the choice of T if you sort of like look for the maximum effect. Obviously, selection of the milestone T before the study is challenging because there may not be enough, let's say, clinical expectation regarding, until which time it is worthwhile to look when the differences, for instance, may occur. And unfortunately, a poor choice of T can result in reduced power of our trial. So RMST is a nice concept, but apart from, let's say, interpretational difficulties, the choice of the milestone is important. And this versatile RMST methods appeared, which allow choosing from a range of T values, the one which maximizes the difference while adjusting a P value. So this seems a nice idea, because then you can sort of like look at the optimal milestone and then test the difference at, taking this choice into account. However, sometimes this can yield a, let's say, clinically questionable statistically significant result by focusing on a particular part of survival curves. Frieden and Korn in this paper actually applied this method to the example of Pembrolizumab and chemotherapy, and they discovered that actually they got the value of the test equal very significant p-value in favor of chemotherapy using one-sided test. And the reason was that this versatile procedure actually selected the first 8 months as the most statistically relevant portion of the curves. So the procedure automatically, in a sense, focused on these early differences, right? And hence selected chemotherapy as the better of the two treatments, clearly leaving out of the picture the late differences. So again, RMST might be an interesting approach which allows to quantify the treatment effect and test it, but one has to be careful regarding the choice of T, and the versatile methods might need to be, let's say, treated. The result of the versatile RMST method might need to be treated with care, and you should always look at how the survival curves look like and where is this milestone which has been selected by the method. Okay, let me go back to something which Everardo also mentioned, the cure, the possibility of cure fraction. This is an example of a trial where we see the overall survival curves, and there is a plateau at about 60 at 5 years, which might suggesting that perhaps we have reached a situation where some of the patients will no longer experience event. I mean, obviously with overall survival, it's impossible because we are not immortal. But let's say that in this situation, one could say that we have a situation where there's a period when this do not happen. This is, of course, interesting question how to analyze this data, and if we have such a cure fraction, the proportional hazard assumption will be questionable as well. How to deal with this? Well, we can look on cure fraction models, and in fact, these models have been developed for a long time. And I have just given this slide to show how many papers were about this method, which actually one might say that there were not very many applications, or not at least not in oncology. But with immuno-oncology, all of a sudden, this possibility of using cure fraction models comes back into the picture. And in fact, you can split these different proposals into two models. One is the mixture cure model. Essentially, the model assumes that the population survival can be expressed as a cured fraction of the patients, so those patients who will never get an event, and proportion of the patients who will get an event and for whom the survival function is actually taking the form of S with the index of subscript U. So we have the mixture of subpopulation which is in a sense cured, immune in a sense to the events, and the population in which events will happen, and then they will be governed by this function. So very often this probability, PX, called incidence for the events, is often modeled by using logistic regression with some covariates. Treatment might be one of these covariates, and then we estimate the long-term treatment effect. And the survival function for the subpopulations which will be susceptible to events is then again modeled in function of some covariates where the treatment effect might be included. Often for this part, the proportional hazard model is used to estimate this short-term effect in the subpopulation of patients who will have an event. And it's worth to mention that if the treatment effect is present in this model for the survival function for the susceptible population, then overall there will be no proportional hazard assumption fulfilled for the for this overall survival function, so for the population, for the entire population. An alternative to this model is something which is called the promotion time cure model. It actually models the survival function for the entire population in this form, where F is a proper distribution function and theta is a known function with an intercept. In this model, the cured fraction is essentially expressed as the exponential function of minus theta of x. And in fact, this model boils down to a proportional hazard model, which is equivalent to the Cox proportional hazard model if we take this function as the theta x function. So in fact, this model is sort of like equivalent. If we choose this function, it's equivalent to the proportional hazard model for the entire population. So these models could be used in a situation where we could see this plateau in the tail of the survival function. However, the issue is that we have got to have evidence of a cure via sufficiently long follow-up. So we have to be sure, or we have to be at least, we have to have got at least empirical evidence that indeed with enough follow-up and we see this plateau in survival functions, and we can sort of like be sure that well, censored observations which are located in the tail of the survival function, that there are perhaps few of them, and then we could sort of like assume that we have indeed reached a possibility of a cure fraction. Now, if proportional hazard assumption is met for our population, for our data, then the cure model provides reliable estimates of the treatment effect. And in this case, of course, the promotion time cure model is preferable. Now, if the proportional hazard assumption is not met, and will often be the case, you shouldn't neither use one or the other unless you are sure that the non-proportional hazards are due to a cure fraction. So, I mean, you shouldn't jump to the cure model if you have a problem with the non-proportional hazards. You should actually check whether you can assume that this non-proportionality of hazards is due to a cure fraction present. And then in this situation, it's better to use the mixture cure model. Now, if non-proportionality of hazards happens for another reason, not perhaps obviously for the cure fraction, then you might use another method like a restricted mean survival time. Finally, let me talk about a generalized method which could be applied in situation of immuno-oncology trials with these different shapes of survival curves. This is the idea of generalized pairs comparisons, which was proposed by Mark Boyce, our colleague from IDDI. And the idea is very simple. Assume that we have a trial with two groups, treatment and control. Let's say that Xi will be the outcome of each subject in the treated group, and Yj will be the outcome of the J subject in the control group. Now, a fully non-parametric approach would be essentially to compare any patient with in the treatment group with any patient in the control group. So assume for the time being that there are no censored observations. You could compare each patient from a treatment group with each patient in a control group and decide whether survival time for the treated patient is better than for the control patient. We will call this pair as a win. There may be longer survival time for a control patient. This would be a loss. And if the two are equal, we would have a tie, or if one of the outcomes is missing, we would call the pair uninformative. So essentially what you could do then is, like in this simple example, 5 patients in the treated group, 5 patients in the control group. With these survival times, we would compare for these patients, we would have survival time of 3 and 9, and essentially these would be corresponding control patients which have exactly the same duration of survival. So we would have 4 ties, 4 pairs which are tied. We would have 23 pairs in which survival of a patient in a treated group is actually longer than for control group, like this guy, 3 versus 1. And then you would have the opposite situation where you have 9 losing pairs. Based on this, you could actually compute the proportion of the pairs in which we have a tie, in which we have a win, and in which we have a loss. And based on these proportions, you could define net benefit as the difference in the proportion of wins with the proportion of the losses. And in this case, it will be equal to 0.39. So in a sense, you would say that this is a difference in like a probability that patient have a better outcome on treatment versus the probability that the patient has a better outcome on control. A similar concept was proposed by Stuart Pocock in 2012. He defined the win ratio as actually the ratio of the proportion of the winning pairs to the proportion of losing pairs. So this is a completely non-parametric procedure, and in fact it can be extended and it can accommodate censoring. It can also allow clinical thresholds of preference. For instance, you could decide that you will call a pair a win only if the survival of the treated patient is longer than survival of a control patient by some clinically relevant amount tau. So in this case, you could actually make a more fine comparison, taking into account the clinical preference. Now, how does this approach work in situations where you might have like proportional hazard or non-proportional hazards? Now, these are like simulations which were fully presented in this paper by Julien Perron and colleagues. We have here the case with non-censoring and censoring. We compare the test based on the generalized Pairwise comparisons versus the classical Logrank test. And in proportional hazard situation, actually you could say that, well, the GPC is less powerful than the Logrank test. However, if you have a delayed difference, so delayed treatment effect, it appears that with a proper choice of the threshold of clinical relevance, you can see now that the GPC approach, so the blue curve, are actually showing a higher power, larger power than the, well, let's call it orange. The orange curves, which correspond to orange curves, which are showing the power for the Logrank test. Obviously, Logrank test has nothing to do with the threshold of clinical relevance. For the GPC, the threshold is important, and as we can see, for certain values of the threshold, we have higher power than the Logrank test in case of the, let's say, late difference. Likewise, if we have a cure fraction or cure rate, we see that again, a GPC approach with or without censoring is actually outperforming the Logrank test. So this completely non-parametric procedure is actually capable of capturing or giving more power than the classical Logrank test in situations like the cure fraction or delayed difference, with which, as we have seen, we can deal in the immuno-oncology. So that's a potentially interesting approach. There's a lot of research going on this approach now, and but it holds a promise if used in this way. So to conclude, Well, traditional analysis using the proportional hazard model for time to event data may be questionable nowadays in immuno-oncology trials, in which we see these delayed effects crossing survival curves, which actually imply non-proportional hazards. As I have shown, alternatives do exist, but they require care in use because they may be vulnerable, for instance, to the amount of censoring or the choices of weights or thresholds, and you've got to be careful with interpreting the results. In any case, you should always consult survival curves, as I was trying to argue, because if we have, for instance, crossing survival curves, and if we use a versatile RMST method, it might be worth to check which actual part of the time scale the method chose for the selection of the milestone, and therefore, for which part of the survival curves they reported a difference in resurrection survival time, and the p-value is reported. I think this is all from both of us. Thank you very much for listening, and I think we can stop here with our presentation.
Yes, thank you very much for that insightful presentation. I would like to invite our audience to continue sending their questions or comments right now using the questions window for the Q&A portion of this webinar. I've already received some questions, so we'll get started with those. Our very first question asks, how do you suggest choosing the weights for survival analysis? Is it pre-planned?
I will take this one, and the answer is simple. Well, it's a tough question, as I said, right? I mean, it's difficult to let's say do it in advance if you have completely no idea how the survival course may look like, right? So, I mean, unless you know where which differences you may want to expect, well, that's a tough question. I would say, in any case, you might go for the, as I said, for a combo test, but that also depends what you put in the combo, right? I mean, you could put Logrank, classical Logrank, and late difference test, but you could also include the early difference test if you are interested in it. So, without any, let's say, prior knowledge, or without any prior expectation, I think it's a tough question, and that's why it's not I don't have a general answer which could help with that.
Well, thank you very much for that answer. Our next question asks, our next question is actually in relation to RMST. The question is, I hear a lot that interpretation of RMST is not easy, but isn't it more a question of getting used to it, rather than RMST being truly difficult to interpret and understand? As an example, they give interpretation of hazard ration is not easy either for people who are not familiar with it.
Well, yeah, I mean, I agree with this comment to a certain extent. I myself certainly do not find the interpretation in terms of hazard ratio intuitive, and Everardo may object as a clinician who is used to use it, but I don't find it very intuitive. Well, I would say that perhaps the biggest challenge might be that if I would like to say to the patient, okay, look, you're on this treatment, you're well, the mean survival time until 2 years is, let's say, I don't know, 1.5 year. Well, the immediate question is actually, okay, so what does it mean until 2 years? Does it mean that I will live until 2 years, or what if I live until 3 years, right? So I think to me as a patient, let's say, not as a statistician, that would probably be the challenging point. And well, but from let's say statistical point of view, I think, and also from practical point of view, I think interpretation in terms of mean time itself is easier than in terms of hazard, hazards or hazard ratio. So I think RMST is closer to have something more interpretationally feasible than hazard ratio. Eduardo, you may want to shoot me on that.
Yeah. Just to complement, I agree completely with what you said, and I would just add the reason why I agree, because I think both are difficult to understand for patients. I would say they're close to impossible, and even to, to people who work in the field, it's often difficult. But I would say hazard ratio is a bit worse, just because it's a relative measure of effectiveness, whereas at least with the RMST, you have an absolute measure that is easier to interpret more intuitively. So I agree with the comment that the person's made or the question, and with your response.
Well, thank you very much for those answers. However, we have reached the end of the question and answer portion of the webinar. Now, if we couldn't attend to your questions, the team at IDDI may follow up with you, or if you have further questions, you can direct them to the email addresses on your screen. I want to thank everyone for participating in today's webinar. You'll be receiving a follow-up email from Xtalks with access to the recorded archive for this event. A survey window will be popping up on your exit, and your participation is appreciated as it will help us to improve our webinars. Now, I'm about to send you a link in the chat box, and with this link, you'll be able to view the recording of this event on that page. And you can share this link with your colleagues when they register for the recording there as well. So I encourage you to do that. Now, please join us in thanking our speakers, Tomasz Berzakowski and Everardo Saad. I hope that you found the webinar informative. Have a great day, everyone. Thank you for coming.
Thank you very much.
Thank you, Ryan.